Hello, everyone. I've made some videos, but unfortunately, I hadn't been able to upload. So I figured what we would do is try to do a recap of the last few last few weeks that we've had, or the last 3 weeks, nonetheless. So let's go ahead and get started. We'll try to be brief with this overview. I know you guys have your exam upcoming, and we've had a lot of lectures in between there. But what we'll do is we'll start off with so we're be coming up on an introduction to hemodynamics in the very near future. However, with a lot of the stuff that we've covered, hemodynamics is just naturally a part of it. So if you can think back to RCP 114, your cardiopulmonary anatomy and physiology course, some of this stuff should be a bit of a review uh, as we begin to look and work through that. So we got to take into account systemic circulation and pulmonary circulation, as well as cardiac circulation or coronary circulation. So uh, all of this is going to have an impact, especially when you start to look at the effects of ventilation, whether it's spontaneous ventilation or the effects of positive pressure ventilation on the chest. So when you have spontaneous ventilation, you've got the thoracic pump mechanism, and then you kindly impede that a little bit when you begin positive pressure ventilation with mechanical ventilation. Uh, so if you have a good understanding of how blood is pretty much routed throughout the body and throughout the uh, cardiopulmonary system, it tends to make things make a little bit better sense. Ultimately, when you're looking at, whether it's anatomy and physiology, pathophysiology, if you're working on a vehicle, putting something together, a puzzle together, what have you, a lot of times if you happen to know, or at least for me, if you happen to know how something normally should be or how it normally functions, it tends to make it a little bit easier to decipher on how to fix it moving forward. And you all know that you'll have questions on your upcoming exam that will have some scenario type uh, or some scenarios there where you'll have to look and determine about those positive pressure effects with mechanical ventilation, what have you. So just to kind of recap and not to be terribly long-winded, because we've already had several hours worth of lecture and class time on this, but just wanted to kind of revamp everything or review everything. Uh, so you know that the veins are colored blue, arteries are colored red. Arteries are colored red because they're carrying oxygenated blood away from the heart, as opposed to where your veins are blue and they're carrying deoxygenated blood back to the heart. Does that mean that the blood's truly blue? No, it is a darker red, as opposed to where oxygen-rich blood happens to show up a little bit brighter red. So the veins carry blood back to the heart. The arteries carry blood away from the heart. Um, so if you can see here, you've got the aortic arch there, and then you have um, the aorta, where it's going to become your descending aorta, your abdominal aorta, and then split off into your left and right femoral arteries and then they continue to kind of change names until they go further and further down all the way to your toes. And then, nonetheless, at the site of gas exchange, you've got the capillary network that's going to take place, and then you're going to have the exchange of oxygen, the exchange of carbon dioxide that's going to take place, and then uh, that blood is going to go into the veins, and then you've got blood return to the right side of the heart by way of your superior and inferior vena cava, so that blood can be circulated around again or go through pulmonary circulation where it's going to undergo gas exchange again and exchange CO2 and oxygen. So down at the tissues within the body, you're dropping off oxygen and picking up carbon dioxide, as opposed to where when that blood makes it back to the lungs, it's picking up oxygen and dropping off carbon dioxide. So when we exhale CO2 and water. Uh, so knowing that the heart is the organ, and I know it's going to sound kind of maybe a bit elementary to say this, but when you're thinking about hemodynamics, you begin to think about the different sides of the heart, the pressures in the heart, whether it's, pulmonary capillary wedge pressure, CVP, right atrial pressure. If you're thinking about terms such as cardiac output, stroke volume, um, afterload, preload. Those are all things that we want to make sure that we have a pretty good understanding as well too. So preload's the volume of blood that makes it back to the heart, but or uh, into the atria, into the ventricles. So you have right atrial preload, right ventricular preload, left atrial preload, left ventricular preload. You can also have an afterload in each one of those as well. So preload is the volume that makes it back prior to the next systolic or contractual event. And then afterload is the resistance against which the heart's got to pump. Uh, so, for instance, you can have an increase in right atrial afterload or an increase in right ventricular afterload. You tend to think about things that might make it more difficult for the heart to be able to pump. Uh, so, for instance, if you've got um, a failing heart, that can certainly be an issue. If you have plaque buildup, atherosclerosis, that can certainly be a bit of an issue. If you've got incompetent valves or stenotic valves, that can be a bit of an issue. Specifically, you're talking about the tricuspid or the bicuspid valves. That's where some of the increase in your atrial afterload may come, whether it's the right atrium or the left atrium. Tricuspid, obviously, on the right side, bicuspid on the left side. So you've got to understand preload, afterload, cardiac output. Cardiac output generically is calculated by means of your heart rate times your stroke volume. You can get in a little bit more detail with the Fick equation. And with the Fick equation, you can have a little bit longer drawn out calculation for determining cardiac output. For all intents and purposes, we'll leave it at heart rate times stroke volume. Right now, our cardiac output is, and remember that cardiac output is the total volume of blood that your heart can pump around through your body within 1 minute at a time. So it's how many liters of blood your heart can pump around in your body within 1 minute at a time. Just as when you're calculating a minute ventilation, you take respiratory rate, multiply that by tidal volume, and that gives you your minute ventilation, which is the total volume of, excuse me, air that you can move in and out of your lungs within a minute worth of time. So at this point, everything really should be tying together and coming together right nicely. So we've talked about systemic circulation. We'll talk about coronary circulation as well as our pulmonary circulation to it. So you do know that you have a systolic or a systemic blood pressure where you have a systolic and diastolic with your systemic circulation. There's also a systolic and diastolic with your pulmonary circulation. And then when you think about the heart and of itself, the heart really you can divide into two different sides. You've got the right side of the heart and the left side of the heart. So if you happen to look at this photo over here in the upper right hand corner of the screen, you have the right ventricle. So and remember, I told you that the veins are discolored blue or colored blue, while your arteries are colored red. So if you and we said that the veins were responsible for carrying blood back to the heart, carrying deoxygenated blood back to the heart, while your arteries are going to carry oxygenated blood away from the heart. So you've got your superior and inferior vena cava here. So that deoxygenated blood returns back to the heart on the right side of the heart. So the right side of the heart receives its blood supply from the body, from systemic circulation. That's going to be important to remember too, especially when we start looking at hemodynamics and when we start talking about what happens to your CVP, what happens to your pulmonary artery wedge pressure, what happens with pulmonary hypertension or PVR, SVR. That'll be more along the lines with systemic circulation, but nonetheless, it's still systemic vascular resistance and pulmonary vascular resistance. That is essentially your afterload when you begin to think about. So systemic vascular resistance would be a direct impact on the left ventricular afterload, or the resistance against which the left ventricle's got to pump. And then the PVR, pulmonary vascular resistance, would be a direct impact on the afterload or right ventricular afterload, the resistance against which the right ventricle has to pump. So ultimately, blood returns back to the heart. Deoxygenated blood returns back to the heart on the right side, and then that blood's going to go through coronary and pulmonary circulation for gas exchange to take place, pick up oxygen, drop off its CO2. That way that the blood can be returned to the left side of the heart by way of the pulmonary veins, and then through the left atrium, left ventricles, up into the aorta and out to the rest of the body, back into systemic circulation. So we've gone through pulmonary circulation to for gas exchange to take place, so that uh, newly oxygenated blood can be sent back out to the body. So we've already talked about in class how important it is to be able to route, pretend you are a red blood cell and route your way through the heart. So you know that you're going returning deoxygenated blood is going to return uh, back to the right side of the heart by way of the superior and inferior vena cava into the right atrium. And then during the systolic event or contraction of the right atrium, we're going to have blood that's going to move from the right atrium uh, through the tricuspid valve into the right ventricle upon contraction of the right ventricle or the ventricular contraction. That blood should now be ejected up through the pulmonic semilunar valve into the pulmonary arteries. Keep in mind, we said that the arteries carry oxygenated blood while the veins carry deoxygenated blood. That is true in systemic circulation. When we begin to think about pulmonary circulation, the pulmonary artery actually carries deoxygenated blood to the lungs, and then that blood is going to have gas exchange with the CO2 or carbon dioxide and the oxygen, where it's going to pick up oxygen, drop off the CO2, and then that oxygen-rich blood now goes out of the capillary network into the pulmonary veins. From the pulmonary veins, that's going to go back to the left atrium. From the left atrium, that blood's going to go down through the bicuspid or mitral valve uh, into the left ventricle upon contraction or the systolic event with the left ventricle. That blood's going to go up through your aortic semilunar valve into the aorta and then out to the rest of the body. So when you begin to look at different pathologies and stuff later on down the road, you begin to think about right side of heart failure, left side of heart failure, and what. So I always tell people it is the responsibility of the heart to keep blood moving throughout the body, and we want to keep blood moving in a forward direction. So, for instance, and it should go right to left. So the right side of the heart wants to keep right side of the heart receives its blood volume from the body. Left side of the heart receives its blood volume from the lungs. Right side of the heart wants to move blood forward into the lungs, while the left side of the heart wants to move blood forward out to the rest of the body. Uh, so make sure that you have a pretty good understanding of that. And I know I'm already talking like 10 minutes or so now, so we'll go ahead and progress to the rest of what we're looking at. Then we've got to review the mechanics of ventilation under normal circumstances or spontaneous ventilation. So you can remember that in order for flow to occur, you've got to have a pressure gradient. So there's got to be a difference in pressure. And typically, when we're talking about ventilation, things are going to go from an area of high pressure to an area of low pressure. And truly, if you think about it, we ventilate or breathe off of a negative pressure system. So we have atmospheric air, or or atmospheric pressure that is available out here at the mouth. You got your airway opening pressure and so forth. You're also going to have uh, you have your intrapleural pressures, your transpulmonary pressures, or transairway pressures that you talk about. We've got to pay attention to the overall anatomy of the lungs. So you've got the trachea bifurcates into your right and left main stem bronchus. That area, the bifurcation is the carina. Then you've got different types of pleura. So you have your parietal pleura, the visceral pleura. The visceral pleura is the actual lining of the lung. The parietal pleura is the lining of the chest cavity in of itself. And there's a potential space in between those, or a pleural space in between those two linings. And there's some fluid in there that helps to lubricate so that those things can glide over one another very well. Also, not pictured in the illustration is the heart. So you notice this little cardiac notch and stuff here within the left lung. You have a pretty good size organ that would sit right in here, and that's going to be the heart. So the heart is positioned in between the two lungs. So when we think about what it takes in order for air to get in, how do we generate a negative, or how do we generate a pressure difference so that flow can occur? So if you allow that diaphragm to contract. So the diaphragm, this big dome-shaped muscle underneath the lungs, it's going to contract. When it does, it essentially creates a vacuum, if you will, inside of the lung. So it's going to create a negative pressure inside of the lung. So if the negative pressure means that it's less than your atmospheric pressure, that's going to allow for air to move down that trachea and into the lungs. Eventually, those pressures are going to equilibrate. And once those pressures equilibrate, that's going to be typically at end inhalation, just before exhalation begins. Uh, those pressures are going to be, so the airway opening pressure would be equal to the pressure inside of the lungs as well. Remember, when you think about mechanics of ventilation, you've got the elastic recoil forces of the lungs. So ultimately said, the forces that oppose ventilation, you've got the outward pull of the chest. So if I were to take a set of bolt cutters and snap my uh, ribs at the sternum, my ribs would want to open up outward that way. The lungs always want to recoil inward. So you've got an outward pull and an inward recoil, or an inward pull, that tend to kind of oppose each other. So after the diaphragm has been contracted and those pressure, and it generates the negative pressure inside the chest and allows for the inflow of air into the lungs, that air has to stop going at a certain point, and it will stop when the pressures equilibrate. So once those pressures equilibrate, there's going to be no more flow. Now you have those elastic recoil forces of the lungs. There's also surface tension that's going to play a role in this. Remember, inhalation is an active process, while exhalation, uh, for your normal healthy individual, should be a passive process due to those the elastic tendency, or the elastic recoil forces within the lung and of itself. And then, like I said, surface tension is going to play a role with that. You know, the surfactant is going to play a role, but we don't want to talk too terribly much about that at the moment. So we've got air coming into the lungs, air coming out of the lungs, and we truly do breathe off of a negative pressure system by the contraction of the diaphragm, the downward movement of the diaphragm. But we also have to think about that downward movement of the diaphragm as it creates a vacuum. Uh, what that tends to do to not just uh, uh, airflow, but it can also have an impact on blood flow within the chest as well. So we talk about the thoracic pump mechanism. That thoracic pump mechanism, as that negative pressure inside of the chest gets generated by the downward uh, motion of the diaphragm, we're actually going to have a situation with spontaneous ventilation through the contraction and relaxation of the diaphragm, so where you essentially help to improve upon pulling more blood into the chest. So it helps to improve your venous return back to the heart. Uh, and then when you have that bit of pressure in there off of spontaneous ventilation, we have to think about that it could also maybe lower the amount of blood coming out of the left ventricle to an extent. It's going to improve the amount of blood coming back to the right ventricle, but could lower the amount of blood coming out of the left ventricle. Uh, so to kind of go a little bit more with what we were saying, again, you've got the heart that sits in between those items. So as the diaphragm goes down, that's going to generate negative pressure that allows air to come into the lungs. That's also going to facilitate the thoracic pump mechanism that actually kind of pulls or improves upon venous return back to the heart. So we have to think about, to an extent, how uh, blood flow and airflow are going to be impacted simply just by taking a spontaneous breath. And then we have to think about, well, in our job as a respiratory therapist, we're likely either going to place a mask on someone's face if we're going to provide non-invasive positive pressure ventilation, or we're going to insert an endotracheal tube or a tracheostomy tube and provide positive pressure ventilation uh, with that. So positive pressure ventilation. So if we go back to this photo here with, now I know it says spontaneous there, but I'm going to utilize this illustration for some of what we're talking about. With positive pressure, there's an artificial airway that's going to blow air into these lungs. So as opposed to there being negative pressure in that uh, within the lung on a breath-to-breath basis, there's now positive pressure. That positive pressure breath is going to slow down that thoracic pump mechanism, and it's actually going to impede blood flow back to the right side of the heart. To an extent, positive pressure ventilation could help with the uh, could help with the left ventricular afterload, make it a little bit easier for the left side of the heart to function, but that's going to be very dependent upon the patient, overall hemodynamic status, and what have you. Uh, so just always remember the normal blood flow through the heart, the pressure differences between your spontaneous ventilation, your positive pressure ventilation, and then you can apply those to the scenarios that you may encounter, uh, uh, whether it's on an exam or in real life, depending upon where you're working at in your ICUs. Um, and then the last thing that we talked about was troubleshooting. Remember, if when in doubt, disconnect and manually ventilate your patient. You really truly probably can't go wrong there. So disconnect and man. I've always said if it's super obvious, go ahead and fix it. But if it's not obvious, you don't want the patient not to be breathing while you're taking the time to troubleshoot what's going on with the patient. So disconnect, manually ventilate. Because when you've got a patient ventilator system, there can be a problem with the patient, there can be a problem with the ventilator, there can be a problem with the ventilator circuit that attaches the patient to the ventilator, um, or it's possible there could be a problem with both. However, you go about with your troubleshooting, just make sure that you're systematic in doing so. We always tend to say, or I always tend to say when I'm teaching, treat the patient, not the monitor. So I think it would be advantageous to begin with the patient and work your way back to the ventilator. You can start by disconnect, but also pay attention to the type of alarm or what it is that you're responding to. What is it that you're troubleshooting? Remember, your high pressure alarms tend to indicate that there's an obstruction somewhere. Now you got to think about what it is that might cause the obstruction to occur. So is the patient biting the endotracheal tube? Uh, is there excessive wheezing when you listen to them? Are they having a bronchospasm, so to speak? Are there secretions in the airway? Uh, has the cuff of the endotracheal tube herniated over the end uh, of the tip of that endotracheal tube? Those are things that, and remember that a high pressure alarm sometimes or oftentimes will be coupled with a low tidal volume alarm, because when you pressure limit or hit your peak pressure alarm, it's going to basically terminate breath delivery. And if you're doing that every breath, then the patient's likely not going to be breathing very effectively because tidal volume delivery has gone down significantly. We want to employ lung protection strategies as best we can. We've talked about those as well. Whether or not you're using a little bit higher respiratory rates and smaller tidal volumes, making sure that you're staying within that 6 to 8 milliliters per kilogram of ideal body weight. Uh, there are some areas that may utilize predicted body weight, but mostly we've discussed ideal body weight at this point in time. So just like we had talked about with an increase in your peak pressures and being accompanied with a low tidal volume alarm, uh, if you have a low pressure alarm or a low volume alarm, a lot of times that can indicate that there's a leak somewhere within the system. So you got to think about common areas where you may find a leak. If you've got any connection to the ventilator circuit, maybe the endotracheal tube cuff is not as full as it should be. Maybe the cuff is ruptured. Maybe the endotracheal tube has migrated a bit too high, and it's not in its appropriate position where it's supposed to be. Um, Look at the little caps, look back at the ventilator, and so forth, because whether it's high pressure, low pressure, if you got a leak, you have an occlusion, that problem very well could be with the patient, or it could be with a machine. For instance, I was working in a neonatal intensive care unit one day and was working with a patient, had gone and gotten the ventilator, set it up, did the EST, provided mechanical ventilation with that patient. After setting that mechanical ventilator up, the ventilator passed its operational verification procedure. And I was able to very effectively manually ventilate neonatal patient with a flow inflating bag. Was doing very well with that. When it came time to attach the patient, uh, the peak pressure alarm continued to go off. Uh, when I disconnected and manually ventilated, I was able to ventilate just fine with the patient. If I attach the patient back, peak pressure alarm began to go off again. So now it was time to figure out what was going on with the ventilator and provide some troubleshooting there. Everything appeared to be patent. You know, there wasn't any type of stopped up HME or anything of the nature that was used. All the conduits were open with the inspiratory limb, the expiratory limb. At this particular point in time in my career, at this particular place that I was working, it was common practice to send the expiratory filters down to be cleaned, sterilized, and sent back up. Uh, so this expiratory filter I had just placed on the ventilator, um, and you know it was fine to pass its pass the operational verification procedure, what have you. But when it came time to put it in action on the patient, that particular filter had never gone through the drying mechanism. It was still saturated on the inside. I didn't realize that when I was putting it on the ventilator. So once was able to switch that out, rerun the operational verification procedure, and get an actual patent expiratory filter in there that would allow the passage of expiratory flow back to the ventilator, then that patient was able to breathe just fine once we got him hooked up to the uh, or once I got him hooked up to the mechanical ventilator with a patent expiratory filter on it. That way, but there was a peak pressure alarm going off with a low exhaled tidal volume alarm because we were peak pressure or pressure limited every breath when that occurred. So be systematic in your approach to troubleshooting. There's a lot of moving parts to mechanical ventilation, positive pressure ventilation, spontaneous ventilation. Remember the basics. Remember the basics of your cardiopulmonary circulatory systems, uh, the way in which blood should flow through those systems, the job of the heart where gas exchange takes place, and then that tends to make when you start talking about, well, this is going to cause an increase in right ventricular afterload, or this causes a drop or increase in your preload, whether it's the right side of the heart or the left side of the heart, then you can begin to kind of critically think about those questions that are likely to come your way by uh, on your unit exams and your board exams when you go to take those. Thank you all for your time and attention. Have a good evening.